welcome to the Pediatric Brain Tumor Foundation's webinar today, Safety First Aid Ready, presented by the Epilepsy Foundation. My name is Heather Held, and I am the Director of Family Support for the Pediatric Brain Tumor Foundation, and I want to thank all of you for joining us today. Before we get started, I have a few guidelines to review. You are muted for this webinar and your video is disabled, but we welcome questions during and after the opening remarks. Please type your questions into the Q&A feature found at the bottom of the Zoom window. We will not get to every question, but we will try to get to as many as possible. I'm pleased to introduce to you today Erin Fecske, a pediatric nurse practitioner in the Comprehensive Epilepsy Center at Children's Mercy, Kansas City, where she has worked for the last 9 years. In this role, Erin manages the care of patients with complex and refractory epilepsy. She is a certified clinical neuroscience registered nurse and has specialized in the care of neuroscience patients for much of her career. She is also recognized as a fellow of the American Epilepsy Society for her contributions to the care of children and youth with epilepsy. It gives me great pleasure to introduce to you today Ms. Erin Fecske.
Thanks so much, and thanks everybody for having me today. I am going to share my screen with you all. So we're going to be going over Seizure First Aid with the Seizure First Aid Ready program. So just briefly, for those of you that don't know the Epilepsy Foundation, Epilepsy Foundation's purpose is that everyone can learn how to help somebody who's having a seizure. And this is important because we know anybody can have a seizure, and that means that anybody can help. So we really want to empower everybody to know what to do if you see someone having a seizure. So some brief disclosures: the Seizure First Aid program is sponsored by SK Life Sciences, and the Epilepsy Foundation is solely responsible for its content. I don't have any personal relationships with industry or conflicts of interest to disclose. You can see our objectives here. So we're going to talk about common seizures. We're going to talk about what you should and shouldn't do to help somebody having a seizure. And then what is a seizure emergency? When do we need to get additional help? So this is broken up into some short modules. So we're going to start first by why, right? Why are we here? Why do we need to learn seizure first aid?
Janet has epilepsy, and she is having a seizure. Would you know how to help her? Stay calm, it's going to be fine. Press next to learn more about seizure first aid. So some seizures can happen anywhere, and they can happen to anyone. So it's really important that we are knowing and that we're learning seizure first aid. So anyone can have a seizure. And in fact, 1 in 10 people will have a seizure during their lifetime. So I always think that this is a really important statistic when we think about who can have seizures, because so many of us don't talk about it. We don't share these things. And so we don't know that people around us have experienced a seizure, when in fact, lots of people are going to experience a seizure during their lifetime. So as we move through the next portion, I want you to think about, we're going to go through some statements, and I want you to think about if you knew that this was a fact, or if this is something that's new to you. So first off, everyone can learn seizure first aid, right? This isn't something that you need fancy degrees or you need training in medicine or nursing. Anybody can learn seizure aid, and everybody should learn seizure first aid. But the first thing to know is most seizures aren't medical emergencies. So we talk about administering seizure first aid, but be aware that this is not necessarily a medical emergency. We'll talk more later about what is. A person may not be aware that they're having a seizure when they're having it, so they may not be able to interact and engage with you. Seizures are not contagious. A person cannot swallow their tongue during a seizure. Epilepsy is a medical diagnosis. And a person can die from a seizure, which I know is a little bit of a scary thing to say, and we'll talk a little bit more about that later. So as we think about risks related to seizures, we're not just thinking about the seizure, but thinking about all that can happen during the seizure. So someone can have a physical injury during the seizure. If you think that they suddenly fall without control of their body, right? They could hit their head on a table, or they could hit their arm. They could have an injury, the kind of seizure that they're having. If a seizure occurs in water, they could have difficulty with that. And then prolonged seizure activity. So typically seizures longer than 5 minutes is what we define as prolonged seizure activity. And then seizure emergencies. And again, we'll talk a little bit more about those, but we also think about early death. So that could be accidents, that could be drowning, that could be breathing or heart problems associated with the seizures. When we think about seizures, we think about kind of that isolated moment, but there are these other risks that are associated with them that we need to be mindful of. So let's think back, right? So we've talked a little bit about why we're here. I know you all have your own reasons for why you're here today to try to learn that seizure first aid, but we want to be thinking about everyone that we could impact with this knowledge. So now we're going to talk a little bit about seizures and what they are, what we're looking for, all of those things. So a seizure is a temporary change in the way that the brain sends electrical signals. So what happens is instead of your neurons doing their own job, right? I want my neurons to send a signal and do this and do that. And I want them to talk to each other, but I don't want them to all be doing the same thing at the same time. When we have a seizure, we get what's called hypersynchronous activity in the brain, meaning the neurons are all sending the same signal. And again, while I want my neurons to talk, I don't want them to talk that closely together. And so we get that, that's when we have a seizure. And the seizure is that abnormality in the way the messages are sent that then causes changes in how our brain and body interact with the world. Seizures can occur with lots of different conditions. So it can be a symptom of several different conditions. We're just going to play this short video.
The human brain is a complex and dynamic organ. The brain contains billions of cells, nerve cells that talk to each other by sending and receiving electronic impulses. Electrical activity in the brain is usually carefully balanced. A seizure occurs when there is a temporary change in the way the brain sends electrical signals. You can think of a seizure as a short circuit or electrical storm in the brain, affecting the way messages are sent. This interrupts normal brain function. It is important to know that every brain has the potential to have a seizure. Every one of us could experience a seizure under certain circumstances.
Some seizures or events do not have changes in the brain's electrical activity when they occur. They are typically symptoms of other physical or psychological problems or concerns. These are known by different names. They are associated with psychological concerns. They may be called PNES, psychogenic non-epileptic seizures. Regardless of the names, the basics of seizure first aid that you will learn during this course should be followed with any event, especially keeping the person safe.
So they introduced a little bit of a new idea there, which is that not everything that looks like a seizure is caused by abnormal electrical activity in the brain. Our job when we're working with someone that we think is having a seizure isn't to figure that out. Our job is to keep them safe and help get as much information to their care team so that they can make further decisions. So we're going to approach both of those things the same for today. And then thinking again about that seizures are a symptom of something, right? So it can be associated with lots of different things. So we need to be mindful of what's causing this seizure for this person. So then the question gets into, what do seizures look like, right? What am I watching for? How do I know if someone's having a seizure? And we'll play this and then we'll talk a little bit more about it.
For most people, when they hear the word seizure, it conjures up an image of a person who has collapsed and is unaware of their surroundings, on the ground, with shaky and jerky movements. This is the way seizures are often portrayed in our media, in films, or on television. But it is not the way all seizures look. Seizures can present many different ways. The outward appearance of a seizure depends on the area of the brain that is involved in the seizure. Seizures can result in a change of movement, sensation, behavior, speech, or a person's level of awareness.
So as we're watching those animations, we saw one person who collapsed to the ground, right, and had generalized shaking. There was one person whose head was moving to one side repetitively. And then this last one, we saw some repetitive eye blinking. So all of those different things can be seizures. I think when we say seizure, when we talk about seizure, the first thing we all think about is that big everything shaking and jerking, right? And that is a type of seizure, but it's important to be aware of other things that could be seizures. So that way, you know what to look for out in the community or for your child, family members, you know what you're looking for. But symptoms are very individualized. And that's the hard part, right? Is because so often we hear, well, watch for seizures, but we don't really know what we're looking for. And that's hard because we're individualizing it to each person. So there might be some information that you can get for specifics, what you should be watching for. And we'll talk about global things to be looking for today. But if someone who is known to have seizures, it's really helpful to ask, what do your seizures look like? Because then you know for that person what to be looking for and what to be watching for, because it's a very individualized thing. All of our brains are different. So all of our seizures can look a little bit different. So now we're going to differentiate a little bit between seizures and epilepsy. So like I said, seizure is a symptom, right? It's that moment where the neurons are sending the inappropriate signal and we're having a change. Epilepsy is a condition, it's a medical condition that's diagnosed when someone has had 2 or more unprovoked seizures, or they've had a single seizure and evidence that they're at high likelihood of having more. So what does that mean? Why did we come to that? Well, partly it's statistics. If someone has had more than one seizure, they're very likely, more than one seizure, they're very likely to continue to have more. So statistically, we say, okay, you have epilepsy at that point. And the same goes for that other side, is if we have someone who's had a seizure and we have an EEG that tells me that you're at risk for more seizures, we're going to put you in that category. So it's this really broad umbrella diagnosis that tells us that someone has epilepsy. Now then the question is, well, what does unprovoked mean, right? When we think about provoked seizures, we think about things like febrile seizures. So kids in particular, super high risk for febrile seizures. Some of you may even have had children who have had febrile seizures where they had an illness, they spiked a fever, and then they had a seizure with that fever. So the fever and the increase in that temperature trigger that seizure. Other times that we think about provoked seizures are if we have a sudden head trauma and then we have a seizure immediately after. So there's a clear cause and response for that seizure. So those things are seizures, they're not epilepsy. So epilepsy occurs when we've had 2 or more unprovoked seizures, or one and somebody has said, yes, you're at high risk for more. So no head trauma, no fever, nothing that happened in that moment to trigger the seizure. So who has epilepsy? We talked about 1 in 10 people having seizures. 1 in 26 people in the United States will be diagnosed with epilepsy during their lifetime.
Epilepsy in their lifetime. Think about your typical classroom that has 26 students. At least one of the students will be diagnosed with epilepsy in their lifetime. Or consider a large sporting event that you have attended. 1 out of 26 of all of those people will be diagnosed with epilepsy in their lifetime.
So I always think that that's a really powerful statistic, right? Because most of us know 26 people, but you would be amazed at how many patients I see, how many kids I see in families. And we're talking about a new diagnosis, and I'll ask them, hey, do you know anybody who has epilepsy or who has seizures? And they'll tell me no. They do. We just don't talk about it. We don't share these things. And so it's one of those things that it's important to talk about, to say, hey, I would know what to do if somebody had a seizure. And I bet if you start saying that, you're going to find more and more people that you know that have been impacted by seizures and epilepsy.
Epilepsy.
So I've talked a little bit about this again, but being mindful of how many people this impacts. But also we've talked a little bit about seizures versus epilepsy. And for us, what we're addressing today is the seizure, right? So we're addressing that acute moment where somebody is having a seizure. So now we're going to get a little bit into the meat about what are we looking for, right? How do I know that somebody is having a seizure? And as we go through this, we've got a mix of animated videos and videos that have graciously been shared with us by people who have been experiencing seizures. And so I'm always very grateful to people who have decided to share that with us, because I think it's really nice to be able to see what this looks like. But I say that because I want you to be mindful of getting all of this, right? So it can be difficult sometimes to watch people having a seizure. I think everybody, the first time they see somebody have a seizure, that first reaction is worry, scared. And so we want to be familiar with them, but take care of ourselves as well. So as we're watching these things, I want you to know that all these videos that have been, again, graciously shared with us, all these people are safe, right? They're all taken care of. They are all safe in that moment. And what we want to be looking for is we want to start watching to see, can you pick up on those clues that something different is happening with these people? So we're going to play this first video and then we'll talk a little bit more.
Before we continue, you will be presented with a short animation and a video from a man with epilepsy named Kevin, who generously shared this footage of his seizures so that you can learn what seizures can look like in real life. See if you can recognize the possible seizure behaviors in each.
Oh, honey, it's okay. Roland, you're okay. Can you hear me? Roland, it's okay. Roland. 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 Can you hear me?
Kevin. Kevin, can you hear me? Kevin? Can you hear me? Are you okay? Can you hear me? Talk to me. Kevin? 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 Can you hear me? Can you hear me? Can you hear me?
Before
Sorry. So as we think about those two, I'm going to go back. As we think about those two snippets that we saw, one of the things that was consistent for both of them was that they had this repetitive movement, right? At first, the gentleman who was eating stopped eating and started repetitively turning his head to that one side. And Kevin was doing something very similar where he was repetitively kind of moving his head and he'd come back. And neither of them were responding when being asked questions. So they were getting a little bit of a vocalization, but nothing that was responsive. So they weren't saying hi or talking. What was coming out was non-purposeful, right? And for the video for Kevin, you might have noticed he was still moving one arm, but his right arm was held kind of fixed, kind of up towards his chest. And he really wasn't moving it very much until the end. And when he did start moving it a little bit, again, it was very purposeless, right? He was just kind of opening and looking around confused. So they introduced a term there called focal impaired awareness. In neurology, we like to sound smart. We like to name things, fancy things. We're literally calling it what it is. So a focal seizure is a seizure that starts in one area of the brain. Impaired awareness, the person who's experiencing that seizure is not able to engage in their environment at their baseline. So focal impaired awareness means a seizure that starts in one spot that impacts the ability of the person to interact and engage. So we have 2 additional videos of similar seizures that we're going to watch. And as we watch this, now that we've talked a little bit about those symptoms that we're looking for, I want you to see if you can pick up on those symptoms and think about what you're seeing that would make you think, something's changed for this person. So we're going to start with this young man wearing the glasses first. Oh. There you go. So he has some repetitive eye blinking and his head starts moving towards that right side. You can see someone touching his shoulder and he's not responding or looking at them at all. And now we're going to move on to this next video.
Excuse me, sir, come on up and I'll ring you out. Come on, buddy, we're out of here at 5 on Sundays.
So in this video, you see we're kind of swaying, we're not responding, and he has that purposeless movement in his hand, as well as a little bit of lip smacking. So those are called autonomisms, which fancy word for purposeless movement. So what are we looking for? What are we going to watch for? Well, what did you hear or see first? So what was that first trigger that made you think, I need to look at this person, something's going on? So I want you to think about that as you're processing through these. What was the first thing that drew your attention to that person? Did they tell you that something felt funny? Sometimes people have a warning before they have a bigger seizure. And so in that case, they might be able to tell you, hey, something's off, something's not right, I might be having a seizure. So if they're able to tell you, fantastic. But mostly we want to know, what was that first thing that made you go look at them? And then during the seizure, we want to know what happened. What was their body doing? How were they responding? How are they interacting with you? Were they awake? Were they not? Were they confused? Were they okay? What was your interaction like? And then what part of the face and body was involved? Was it just their face? Was it just an arm? Was it their entire body? What were you seeing? What was moving? And how was it moving? Saying it was shaking isn't really as descriptive as we would want. We would want to know, is it jerking? Is it tremory? Even showing with your body to the medical team what you were seeing can be really helpful. And then did you notice changes in speech or behavior? So in those videos that we watched, right, that was a change in behavior where they're not responding. But sometimes what we'll get is a change of speech. So someone may talk and pause and then kind of continue, or they may start a thought and stop and say, where was I? What was happening? Where were we? What were we talking about, right? Or even they might repetitively say the same word over and over again, where you're like, hey, how are you doing? What's going on? And all they say is, okay, okay, okay. So those are changes in speech and behavior that we want to be aware of. Now, that means I'm asking a lot during a seizure, right? For someone who doesn't see this every day to say, hey, I want to know all of these things, that's asking a lot. But as much as you can remember is really, really helpful for the team moving forward to decide what to do, how to help them, all of those kinds of things. So the more information you can gather, the better. But also, as the medical team, we all know we're asking a lot of bystanders and parents and caregivers and friends. So as much as you can give is fantastic. And I can't ask anything more from anybody. So then after the seizure, what do we want to know after? Well, we want to know how long did it last, right? Because how do I know if it's a seizure emergency if I don't know how long it lasted? So we want to know how long it lasted. And we want to know, did they get back to themselves, right? Did they get back to their baseline, or was there any unusual behavior afterwards? And if there was, how were they after? Were they tired? Were they confused? What else was happening to that person after the seizure? So that's all really helpful for us and helpful in how we're going to approach that person, as well as how you're going to approach that person after the seizure. So we're going to get a little bit nitty gritty into kind of what these seizures might look like and how we're going to approach them. So seizures that have confusion or unaware, one of those types, focal impaired awareness seizures, which we talked about a little bit, right? Those are those seizures that start in one spot and they impair the person's ability to interact with their world. So they are somehow not able to engage and interact with you. So during that seizure, someone might not be aware, or they may look confused, right? They look around like, I don't know who you are. I don't know what you're asking me. The words that you're saying may not make sense to them, or they may make sense, but that person can't express themselves. So they might have a blank or kind of a dazed stare. Those autonomisms that we talked about, which is a repeated purposeless movement. So a lot of times we see picking, they kind of, will pick at their clothes or bed sheets if they're in bed. You might see that lip smacking or kind of chewing, swallowing motions, those repeated motions. They might be clumsy. So if you're playing cards, maybe they put their cards down and it's just like this big plop, right? Or they reach and it's just like they can't get what they're looking for. So they're not able to move with their normal fluidity. They may or may not be able to talk. And if they do talk, it might not make sense, right? The words might not make sense, or it might sound like gibberish. So there's changes in how they're talking potentially. Oftentimes, these seizures are followed by a period we call a postictal period, which again, fancy word for after seizure, for the recovery after seizure. So they might be tired after that. They might complain of a headache or an upset stomach. They might just be really, really lethargic, might need to take a nap, may have some aches. All of those things can happen. And for someone experiencing a focal impaired awareness seizure, they may become combative or irritated if we try to restrain them. So if we try to keep them from doing what they're doing, they may become irritated by that. Focal impaired seizures typically last 1 to 3 minutes. So they don't typically last super long, but when you're with somebody who's experiencing a seizure, it feels like an eternity, right? So that feels like a long time. These seizures can be confused with someone who's abusing substances, whether it's alcohol or other drugs, aggressive behavior. If you are only catching the person at that end of the seizure, right, those after effects, it can be confused with aggression or mental health issues. So it's important to, again, note what you're seeing and try to tease out what are the features here, right? What am I looking at? And also be aware that if you see someone, you're like, I don't know what's going on with them, a seizure might be the thing that's going on with them. So this is another video of someone who's going to share their focal impaired seizure with us.
I have epilepsy, and I'd like to share my seizure with you. I want you to see it so that you won't be afraid. When you have epilepsy, you ask yourself, when will the seizure happen? Who will see? Am I still me? But I'd rather ask you, would you know how to help me when it happens? Do you know there are different seizures and that they look very different? Could you have epilepsy and not know it? There are many questions. Find answers at epilepsy.com.
So I really love those videos because it does a great job of showing the different features. So in that last one, you see her kind of pulling at a string on her hoodie, and that's that autonomism. You heard her trying to talk and the word just wasn't coming out. And you could even see she was frustrated, like, we were trying to get our point across, but we were having that very different movement. And you could even tell from when you were interviewing and you see her talking to the seizures, her facial features look very different. So it's very evident that something's changed for this young woman. So we're going to move away from the focal impaired awareness seizures and talk about seizures with staring and not aware. So we talked about how focal seizures start in one spot in the brain. Now we're going to talk about seizures that start on both sides of the brain. So by nature, when seizures start on both sides of the brain, we don't have awareness. So people who have seizures on both sides can't interact, can't engage. So one type is a generalized absence seizure. You might read this word and say absence. That would be fine. But most of our terms come from Europe, particularly France. And so we like to put on our French and say absence seizure. But this is a generalized seizure. So both sides of the brain. And this is a very brief pause, a blank stare. They might blink. They might have some eye flutter, might chew a couple of times. This can happen a couple times a day to hundreds of times a day for people with this type of seizure. They might look confused, daydreaming, might be confused with attention difficulties. But oftentimes, these are things that teachers will notice very quickly. I think teachers are one of my best gauges on these because they're working with kids and teaching, and so they see those pauses that they're having. But these are very, very brief. They're less than 20 seconds, and again, can be confused with daydreaming and attention. What's the difference? The big difference is if someone's daydreaming or if they have attentional difficulties, if you touch them, right? If you're like, hey, Johnny, you with me? They're going to be like, yeah, like what's going on here, right? Versus if someone's having an absence seizure, if you touch them during the seizure, they're not going to be able to respond. Now it's hard because they're really, really short, right? But that's where getting that expert team involved if you're concerned is helpful. And we do have a brief video of an absence seizure. So I will share that and then we can talk about it. So you see how brief that was, right? You see her looking and engaging at the camera, and then she takes a second and her eyes drop and her facial features drop. And that lasts just a few seconds. And then she looks back up at the camera like, where was I, right? What was happening? I'll play it one more time for you. And then we're back, right? So these are very, very short seizures. So now we're going to move on to a tonic-clonic seizure. So remember when we talked back about kind of like, what do you think of when you think of a seizure? This is what everyone thinks of when they think of a seizure. So these used to be called grand mal. We now call them tonic-clonic seizure. Why did we change the name? Because it's more descriptive. So tonic means stiff and clonic means rhythmic jerk. So we are literally describing what we're seeing. With a tonic-clonic seizure, you might have a sudden cry, and that happens because that big muscle that's involved in breathing gets tight and we expel air out of our lungs and through our vocal cords. So you might get this cry. People lose consciousness at the onset of the seizure and they fall. So we get stiff and we fall over. Their body is stiff, everything, arms, legs, everything gets stiff. And then we have this rhythmic jerking, okay? And it's not necessarily tremoring, although you might see that. It's more just this very rhythmic jerking, both sides of the body moving together. For anybody who's musician, that you can set a metronome to it, that's what we're talking about when we're talking about that rhythmic jerking. People having a tonic-clonic seizure are going to breathe very shallow. They might have a lot of drooling, a lot of salivation during that time. They potentially can lose bowel or bladders. They might, have urinary incontinence or bowel incontinence. You might notice that their lips and skin look kind of gray to blue. And primarily you're going to see that kind of around their lips. But you might even notice that their face gets a little bit ashen. The reason that happens during these seizures is because it takes a lot of energy to have this rhythmic jerking and all this stiffening. And so your body knows, hey, I need blood in important places. And important places are brain, heart, organs, right? And important places are not my skin right now. And so all of those blood vessels get really, really tight, and that's what creates that color change look. Oftentimes after a tonic-clonic seizure, people are confused, they have a headache, they're fatigued, their muscles hurt, they might have some slurred speech or difficulty with speech, like they're really processing hard to get that word to come out. So all of those things might happen When I talk to families about tonic-clonic seizures, I always tell them it's like you ran a marathon and you didn't train for it. So it's a lot of work, it's a lot of energy. These typically last 1 to 3 minutes, and again, often followed by confusion, headache. You might notice that they've bitten their tongue, or again, have that speech difficulty. But the seizure is done when that rhythmic shaking and jerking is done. And that after period is that recovery period. So we do have a video of somebody who's experiencing a tonic-clonic seizure. Again, this person is safe. They are being monitored closely, but we're going to use this to help us learn, help us visualize what we're looking for when we're going to help somebody who's having a seizure.
We'll watch a video from a man with epilepsy named Kevin who generously shared this footage of his seizures so that you can learn what seizures look like in real life. Here, he is being observed in the hospital in an epilepsy monitoring unit, or EMU. Brain monitoring can capture the patterns and location of seizure activity in his brain and help determine the best treatment for his epilepsy.
It's been pushed.
I'm going to pause it here because I want to note they were the voiceover covered it a little bit, but you heard a little bit of that cry at the beginning, and then you see he's now that rhythmic shaking.
We'll watch a video from a man with epilepsy.
It's been pushed.
They're talking about pushing an event button in the hospital.
Just in case. I'm going to push it again, okay? Because he pushed it earlier. It's coming out.
So you can see at the end of that, first off, the medical team came in, they kept him on his side, they all stayed calm, right? And you heard them talking to each other about, the drooling and do we need to take care of that? And what do we need to do to keep him safe? So absence and tonic-clonic are kind of the big seizures that we think about when we think about generalized seizures. There are other types of generalized seizure. One other type is called atonic. So if tonic means stiff, atonic means loss of tone. So people who are experiencing atonic seizures can suddenly fall. And so in this example, we're seeing somebody who is in a wheelchair out for lunch, and they will suddenly have that head drop, that atonic, that fall. So that's another type of seizure that's a generalized seizure, less commonly seen. We do see it in pediatrics with epilepsy syndromes, but it's less common of a one that is seen. So we talked about kind of what to look for seizures. And so now we're going to talk about what we're going to do, right? So we talked about looking for changes in how someone's behaving, rhythmic movements, things that you can't interrupt, you can't get their attention, changes in how they're interacting or engaging with the world, and that purposeless movement, right? So now we're going to get to seizure first aid, right? So we've talked about what seizures are. We've talked about why we need to learn seizure first aid. We've talked about how to identify it. Now we're going to give you the what to do. So seizure first aid, we have our 3 basic principles: stay safe, side. And then we always want to keep 5 in the back of our mind. So 5 minutes is our threshold. So we're going to stay with them. We're going to stay with them until they're awake and alert. So remember how some of those seizures can have confusion and fatigue afterwards. We still want to stay with that person during that time. We want to time the seizure. So I do not trust your judgment of time when you're experiencing a seizure, when you're helping someone who's experiencing a seizure. I want you to look at your watch, pull out your phone, set a timer, time that seizure. Stay calm. Remember when we talked about those facts and falses about the seizures at the beginning, and remember how most seizures are not medical emergencies. So we want to remain calm. Check for a medical ID, right? If someone has a known history of epilepsy, They may wear a medical ID. A lot of times those are digital nowadays. So you can check their phone to see if they have a digital medical ID as well to see, is this something that happens for this person or is this brand new? And then we want to keep them safe. So we want to guide them away from harm. So if they're having a focal with impaired aware seizure and they're still moving, we want to guide them away, keep them safe, right? We don't want to restrain them, but we want to guide them. We want to get them on their side. If they're laying down, we want to roll them on their side. Remember in that video where we were witnessing the tonic-clonic seizure and the medical staff helped keep that gentleman on his side, keep Kevin on his side, keep him safe. If there's anything tight, if they're wearing a tie or have anything tight around their neck, we want to loosen anything, unbutton the collar, keep their airway clear. How do you do that? Well, you have them on their side and everything stays nice and open. Make sure that there's nothing around their face. If you're out, if you're on the floor, tuck something soft under their head. So a sweater or a pillow, a blanket, a towel, something to keep them safe. So seizures can happen anywhere. That's why we're here, right? It's because this can happen anywhere. So we want to pay attention to safety. If you're in an area near trains or something else, what is dangerous in this area? Cars, what can we do to protect this person? So guide them away. Again, we don't want to restrain them unless it's absolutely necessary to prevent injury. If they're about to fall or if they're unconscious, lie them down. But we don't want to leave that person alone. We want to stay with them. A lot of times beyond that, basic first aid is all that we need. But if they're alone, if they're not recovering, if you don't know this person and don't know if they have a history of seizures, we need to call for help, right? So what don't we want to do? We don't want to restrain them, right? I've mentioned that a couple of times. We don't want to restrain anybody who's having a seizure. We don't want to put anything in their mouth. And we're not going to give them anything until they're awake and able to ask for it or back at their baseline. If somebody has a history of seizures, they often have a seizure action plan, and you can follow that as prescribed by their provider. So emergency medicines might be recommended, in which case that would all be outlined in that plan.
One of the most important parts of caring for a person with seizures is to make sure that you don't put anything in their mouth. One of the biggest misconceptions about seizures is that a person having a seizure would swallow their tongue, and that's simply not true. You shouldn't put anything in the mouth of a person having a seizure until they're awake and they are able to swallow. The one instance where it might be okay to put something in the mouth is if they have a rescue medication that has been prescribed by their medical team to be given to in the mouth to stop their seizures. We don't want to restrain a person when they're having a seizure, so don't hold them down. If they are walking around, you don't need to hold on to them unless they're walking into a dangerous situation, in which case you want to redirect them away from that situation. What's most important here is that we're not trying to make the situation any worse. And sometimes when seizures are over, people can become somewhat aggressive or combative. And for these reasons, we don't want to restrain them or hold them.
So now we're going to watch a video that's going to help put all of this together, okay? So remember, we're going to identify that somebody's having a seizure by watching for that change in behavior, repetitive movements, inability to respond, all of those things. We're watching for those things. We're going to identify the seizure. We're going to stay safe sides. We're going to stay with them, during which time we're going to time it. We're going to observe what's happening. We're going to keep them safe, whether that's redirecting, helping put something under their head, moving anything nearby that might be dangerous to them. And then we're going to get them on their side.
Now that you have learned about seizure first aid, let's watch a video demonstrating the basic principles of seizure first aid. Hey guys, give us some room. She's having a seizure. Okay, it's 5 p.m. Give me some towels, please. Stay calm. It's going to be fine. move the basketball out of the way and help me get her on her side. Okay, it looks like she's coming back to us. That seizure lasted 2 minutes. Okay, Michelle, we are here for you. It's okay. All right, listen up, guys. Before we practice, I want to go over a couple of things. We all know Michelle has epilepsy. She had a seizure during the game, and she has something she wants to say.
Yeah, thank you for supporting me, and thanks to Coach for knowing what to do. I'm sorry my seizure scared you guys. It can be scary for me too, but what's even more scary is if people didn't know what to do.
So today, we're going to learn Seizure First Aid thanks to the Epilepsy Foundation. We're teammates, right? We take care of one another. We count on one another. When anyone has a seizure in front of you, you become their teammate, and they are counting on you. So first, stay with her, okay? Stay calm, and keep others around you calm and out of the way. Protect her. Keep her safe. Stay with her all the way through. It's also important to remember the person having the seizure may be unconscious, and you need to make sure there is nothing harmful or dangerous around. As soon as you realize someone is having a seizure, look at your watch and start timing it. Knowing how long the seizure lasts is important information for the doctors to know. If the person looks like they are unconscious and going to fall over, even if they're in a chair, guide them to the ground. Support their head so they're not banging it. Grab something soft like a towel or a piece of clothing and place it under their head. Turn them on their side and put their head toward the ground so saliva comes out and doesn't go down their airway. Never put anything in their mouth. This could injure them or injure you. Do not hold them down or restrain them. If the seizure lasts more than 5 minutes, call 911. When you see someone having a seizure, you're going to feel a little scared and a little powerless. But if you protect them and stick with them by their side, you're doing the right thing. All right, let's practice this. Bulldogs on 3. 1, 2, 3. Bulldogs!
So sorry, I love that video because I think it just does a great job of bringing everything together. So we've talked a lot about what to do, that most seizures aren't medical emergencies. When do we need to be worried, right? When do we need to get that extra help? Well, we need to get extra help if the person has a medical condition or is pregnant. So that way we can make sure to keep them safe. If they're not coming back to themselves, we need to get extra help. If it's a first-time seizure, or if you're seeing somebody out in the world and you don't know, right? We're going to assume it's a first-time seizure. We need to get extra help. If they're having a prolonged or repeated seizure. So prolonged is anything more than 5 minutes, and repeated, if they've had a seizure, we've rested, the seizure stopped, and then it started again. That's again when we need help. If they're injured, so we talked about injuries that could happen during a seizure. If you're worried that somebody hit their head or something else happened, get them extra help. If they're having difficulty breathing, obviously we need to get extra help. And then any seizure that happens in water is an emergency. We just need to make sure that no water got into their lungs. So after the seizure, once you've done all those other things and you've taken your deep breath, we want to share what we observed during the seizure. Remember, all that information that you can remember is really, really helpful. Stay calm. So I find taking a deep breath before you respond is really helpful at bringing your heart rate down. Remember what we said at the beginning, most seizures are not medical emergencies. So it can be very scary to watch. Take that breath, remember that, and be with that person. Stay with them. Stay with them until they're awake, alert, and back to their baseline. If they're out, if you're not, this isn't somebody that you know or somebody that you do, offer to call somebody else, right? Do they want a family member? Is there a friend that normally takes care of them during this time? What can you do to help them? Make sure that they have a safe way to get home if they're not home. And if you did call 911, if EMS was called, give them as much information as you can about what you saw, what you did, and what you experienced and what you saw that person experience during the seizure. So with that, we're going to play this one last video and then wrap up.
When I had my first seizure, one of my school nurses did an excellent job helping me to calm down as I was unaware of what had happened. So she calmed me down. She let me know they had called the EMTs and that they had also contacted my mom and that she was on her way. And helping an 11-year-old scared girl calm down after her first seizure was so important to me because I was able to go to the emergency room unafraid, which was my first ever emergency room visit.
Epilepsy is an unpredictable disease, and seizures can occur at any time and any place. And that's why it's important for everyone to be aware of what seizures look like and how to deliver seizure first aid, because you could help save the life of a loved one or a stranger having a seizure near you.
So with that, I am going to say thank you so much. We're going to put this up in the chat as well, that you can go back to that or go back to the learning portal to complete your post-assessment. That's really helpful for us so that we know that the education that's being provided is helpful to people. So if you can complete that, that is wonderful. Upon completion, you'll get this lovely certificate that says that you are Seizure First Aid Ready. And thank you so much for being here. Thank you for taking the time out of very busy schedules to learn this, because it's really, really helpful to people. So thank you so much. And thank you guys for inviting me. And at that point, I think we have some time for questions.
Thank you so much, Erin. I have a page and a half of notes. So I
love notes.
I really appreciate the information today. We did have a couple of questions come in. Early on, when we started talking about the seizure types, a attendee had posed the question, is it safe to say that many of the things that indicate possible seizures are similar to things we see with kiddos who have autism or other cognitive impairments?
It can be, and it can be difficult, right? Because when you think about kids with autism, they have a lot of repetitive behaviors. Those tend to be much more complex than for a seizure. So when we think about repetitive behaviors for seizure, I'm thinking about kind of a rhythmic jerking, not necessarily things like the hand flapping or the hand wringing that you might see with somebody experiencing autism, or kind of the rocking that you might see. The big thing is that with an autism behavior, you can interrupt it. They might not like it when you interrupt it, but you can remove that stimulus. You can get them up and they would stop doing what they're doing. If you cannot interrupt that behavior, we need to at least get a medical professional involved to help differentiate what's seizure versus what's not. So yes, it absolutely can be difficult. And that's where getting that team of professionals is really helpful.
Thank you for that. Another question that came in is, I would like to show these animated videos to my daughter's school. Can they be found on the website for the Epilepsy Foundation? And Cheryl, there we go.
Yeah, I was going to say, Cheryl, I believe, dropped those resources in the chat. Okay. And there also are on-demand versions of this that you could access to. Because I agree. I think those animated videos are really, really helpful to visualize what we're looking for. And just to learn a little bit more about seizures and epilepsy, because I think it's cool.
Yeah,
I think it's good thing to learn.
Yes, thank you for that. We will be sending out a handout from today's presentation from the Epilepsy Foundation to all of you attending, and we will also send a link so that you can watch the webinar again and pick up more information. I really want to thank you, Erin, for your time today and sharing your expertise and experience with us. Thank you to the Epilepsy Foundation for partnering with us to provide this important training to families. And finally, I want to also thank you, our attendees, for your participation, your thoughtful questions, your interaction. This slide that you see here, you do not have to write down this URL. I will be sending it out to you. And then also the next two slides have the contact information for the Epilepsy Foundation, as well as the contact information for the PBTF. We remain here for you no matter where you are in your journey. So please contact us at any time. And I look forward to seeing you all on next month's webinar. Have a great day.